Hi, so I'm here today to run through RSI assistance procedures. We're here with our patient who is a young chap who's fallen approximately 6 metres off a roof whilst water blasting. He's landed on his head and has got occipital injury, which is quite boggy, approximately 6 centimetres in length. We've done our primary survey when we got to him, and we've had a good look and a good secondary survey of his whole body to check for any other injuries. We've not found any pelvic injuries or anything else that needs to be treated. We've just got this isolated head injury. The patient is combative, and he's got irregular respirations. He's got a GCS that we have found to be about 7. So we've got eyes 3, voice 2, and a motor score of 2 because he's extending when painful stimuli is given. So when we're assessing this patient and what's happened to him, we're trying to work out the level of compromise for his TBI that he's got. So with his irregular breathing, he's a little bit bradycardic, so his heart rate is 50, his blood pressure is 160 on 110. He's got a rest rate of 12, which is really irregular. BGL 7.6, temperature of 37. So with what we're looking at with this patient, we're considering things like Cushing's triad, where you would have bradycardia and irregular respirations and hypotension. At this stage, he's not hypotensive, but everything that we're looking at here, the systemic involvement, his head injury, could lead down that path. So a TBI, to describe what a TBI is, it's an impact or penetration or rapid movement causing brain injury in an altered mental state. So with a GCS of 10 or under, with the agitation that this patient is presenting to us, we are considering RSI for this patient because he's so combative. Treatment as it stands at the moment would not be able to be provided safely for him. So we have called for RSI. So we've called over the radio and we've asked for R50 for RSI, and we've got one on the way, and it's going to be approximately 10 minutes. So in the meantime, what we do, we need to prepare our patient for the RSI. So we're thinking about all the risks and benefits of doing this for our patient. The risks involved for this RSI is the potential for hypoxia or hypercarbia, increased cranial pressure when doing the laryngoscopy would be a potential risk with decreased cardiac output, and then if CPR is required, then blood flow could be an issue as well. But the benefits should outweigh this, which would be securing this airway, which we need to protect the lungs from any aspiration of vomit. We need to control our CO2 levels and improve oxygenation, which is why we have PEEP on standby here with our manual ventilation bag. So we've recognised that this is actually a severe TBI, so we want to prevent any secondary injury, which would be caused by hypoxia, hyperventilation, hypoventilation, and hypotension. So this is why we're looking at RSI. We've got our fluids all set up here, so that's already. We've got both arms have got IV large bore cannulas in, fluids set up so that we can open that up if we need to maintain a systolic blood pressure of 120. We don't need that at this stage because we've got a blood pressure of 160. And we've got our end tidal set up on here as well, which we want to, got a target on there at 30 to 35. Okay, so recognise this is severe TBI. We treat any other life-threatening injury, so we've already looked at that. And then what we would plan to do is transport to a major trauma hospital in the area. Right, so we have got things all set up here. So before our backup comes along, we will need to go through our RSI checklist. So we've got preparation for RSI checklist. So myself and my crewmate will be aware of all our treatments and things that we're trying to do here. So we've attached the nasal prongs here without any oxygen, but we're ready to pre-ventilate to make sure that we've got oxygenation up using the reservoir mask at 10 litres a minute. And we've got our manual ventilation bag here ready with the PEEP set to 5. Attach the ECG, so we've got all that set up. We've got blood pressure cuff and we've got SpO2 on. Prepare capnography, we've got that ready. Position the monitor so it can be seen, so I can see that quite easily here. Leaving space to the right side of the patient's head here for all the R50's intubation equipment. We've got IV access both sides. Got the running line ready. Position the patient optimal airway control, so we've put a towel under, we've got the sniffing position all here ready. ETT holder with the strap undone but ready to go right here. Suction is here and we've checked that it's working and turned off. Manual ventilation bag with PEEP attached. Set of vital signs already done. Obviously with the RSI officer being at least 10 minutes away, we would get a second set of vital signs prior to them arriving. Update responding ICP with patient's condition and vital signs. So if anything were to change, we would get on the radio, talk to the ICP and ensure they're aware of anything that's changing. Prepare the area. We're not in an ambulance, we clear the area around the access to both sides. And if they are in the ambulance, we'd clear away as much unnecessary equipment as we can and consider moving towards the backup if we've got it there. So that's our preparation all complete here. And then once our R50 backup arrives, then we would be going through our RSI checklist with them as follows. So we'll need the roles assigned and team brief. So we'll need someone for airway, someone to assist with the airway and someone to help prepare the drugs. The patient is all prepared, pre-oxygenated, nasal prongs in place, position's been optimised, IV access, running line and fluids ready for bolus if we need to. Monitor attached visible, baselines all done including ECG and blood pressure, pulse oximetry and capnography. Equipment checked and ready, that's all been done. Manual ventilation bag with PEEP set. OPA here ready. Laryngoscope checked by the ICP prior to arriving here. ETT cuff checked with the syringe containing 5 ml of air. ETT cuff holder in place, suction checked, bougie, LMA and cricothyroidotomy equipment all out and ready in case we have a failed intubation. Drugs will be drawn up and dosage confirmed with atropine if we're bradycardic, fentanyl, ketamine, sux and morphine midaz and rocuronium for the RSI. Then the failed intubation plan will be communicated if required. So once all that's been complete and we've gone through the drill for the RSI, we then do the post-intubation checklist as well. So we've got that here with us, confirming placement with capnography, noting the end-tidal levels at the target of around 30-35. Examine chest for any signs of bronchial intubation, adjust the ETT depth if required. Secure it and note the length of the lips. Cervical collar, so with our patient that's fallen such a height, a cervical collar probably would be indicated. So we make sure that that is replaced after the RSI has been done. Remeasure the vital signs again, considering administrating any sedation and neuromuscular blockade. Check oxygen supply, check ETT cuff, ensuring cuff contains only the minimum amount of air required to provide a seal, and ensure a bag ventilation mask is immediately available if a mechanical ventilator is being used. So we then need to think about a failed intubation drill. So if something goes wrong, if we can't quite get that intubation done properly, if we're unable to visualise the chords within 15 seconds or unable to intubate within 30 seconds, then we need to think about manual ventilation and retrying with bougie, perhaps optimising the position but using a different blade or giving some burp pressure. If end-tidal CO2 is more than 5 millimetres after 2 to 4 breaths, then yep, that's all good, it's been successful. If not, we've removed the ETT and we replaced using an LMA and normal airway management. If we're able to ventilate, that's great, we'll continue doing it that way. If we're not, then our ICP will need to think of a cricothyroidotomy, which is cutting into the rings down here and providing ventilations that way if we can't get any airway management in there. So that's our overview of our RSI assistant as a paramedic for prior to our RSI R50 arrival. Thank you.